I intend to present my paper on quantification of ocular trauma. This is a place where I work in Ratan Jyoti Netralaya and Research Center. I can see a photograph of a lady who's quantifying vegetables. And here she has quantified potatoes, 1 kilo potato, very easily and very accurately. And she can quantify other vegetables also so easily. I wish I could quantify ocular trauma also so easily and so accurately. Unfortunately, it's not possible. Now, quantification. It's easy and accurate in basic sciences like physics and mathematics. In medical science, it's difficult and complicated. Hence, some compromise becomes necessary. Even then, there is a rapid shift from qualitative to quantitative assessment. Quantification in medical science, earlier decisions were taken mainly on clinical experience. Few things like pulse, blood pressure, and temperature could be quite accurately measured. However, symptoms like pain, redness, watering were difficult to quantify. Coming to ocular trauma, it is not a single disease of a single part of eyeball or adnexa. It is caused by a variety of agents in a variety of ways. Accurate assessment is difficult. Even then, some assessment is useful for many reasons. Now, the quantum of damage depends upon the mass and velocity of the striking agent, its site and direction, its chemical nature, duration of contact, and delicateness of tissue or tissues involved. What are the methods for measurement? Usually, the quantum of damage is assessed irrespective of the causative agent. Functional damage is more important as it affects the earning capacity. The structural damages affects the appearance and therefore is of cosmetic importance. Damage to both type of structural and functional is added for both the eyes. Earlier method. Ocular trauma usually affects children and young who have normal vision. Vision after trauma is noted, which is a measure of damage, presuming that pre-trauma vision was normal, as is in many cases. But it's not always so in many cases also. Now, what are the methods that have been tried for measuring ocular trauma? The primary assessment, it is done soon after or at the earliest time. So that's the first assessment. And it can be done by trauma index. For prognosis, ocular trauma score has been developed and is calculated from the primary assessment. Then total loss is calculated from ocular traumagram, which I'll be presenting. Now, coming to trauma index, this paper was published as early as 1981 in the All India Conference at Pune, and it was published in Indian Journal of Ophthalmology, where TI is trauma index is half into bracket S upon 2 plus F into T upon 100, where S is the structural loss calculated in percentage, F is the functional loss calculated in percentage, and T is the approximate recovery time in percentage. Now, structural loss, not only of the eyeball, I would like to stress this point that when we talk of ocular trauma, it's not only the eyeball, but ocular adnexa also, including orbit, lids, lacrimal apparatus, etc. So, when we say structural functional loss, we must include orbital adnexa also. So, if 20% is for mild loss, 40% for moderate loss, 60% for severe loss, 80% for very severe loss, and 100% for total loss. So, this is how we grade roughly on clinical experience as to what is the structural damage. Now, in functional damage or functional loss, mainly it's the visual acuity. And this is said by post-trauma vision, presuming that pre-trauma vision was normal. If it was not normal, then we have to take that consideration separately. So if the post-trauma vision is 6 by 6, that means the loss was 0%. And then as you go on, 10% is added to further loss for every line. So 6-9 is 10%, 6-12, 20, 6-18, 30, 6-24, 40, 6-36, 50, and 6-60 would be 60% loss. Then further, if it is less than that, then it's a measure in steps of 5. 5 by 60 is 65%, 4 by 60 is 70, 3 by 60 is 75, 2 by 60 80, 1 by 60 85, count finger hand movement 90, PL plus will be 95 and no PL will be 100%. So if trauma, you don't have no PL, the loss is 100%. However, as I said just now, that visual function does not consist only of the visual acuity. We give it 80% significance to the visual acuity, but 5% for the fields, 5% for motility, 5% for ocular tension, and 5% of lacrimal dysfunction. Just now we had on dry eye, we had a nice symposium just before this. So they are also important, and therefore we take into consideration, and that gives you calculate the total functional loss in percentage. Now, importance of time, because this is very important. 3 persons may be injured in an eye in 3 different ways, and the vision may be 1/16 each. First may recover in 4 days, second in 4 weeks, and third in 4 months. And therefore, initial assessment is equal, which is misleading. So therefore, the time of recovery has also to be seen. Hence, in trauma index, time is considered. Now you see, of course, they are not patients, they are people from my staff of our institution. And one is affected by a table tennis ball, one by a shuttlecock, and by a hockey ball. Now this is a presumption. Now one will, table tennis ball may recover in 4 days. The one with shuttlecock may take 4 weeks, and with a hockey ball may take 4 months. But vision was 1/16 in all the cases. So would you give the equal importance? No. We have to see for what time this visual loss has occurred. Now recovery time, again we have worked out in percentage. 1 day is 1%, 2 days 5%, like that. 5 days, 1 week is 30%, 2 weeks 40%, 3 weeks 50%, and 4 weeks 60%. So that's on recovery time, the time percentage equivalent has been given. Further, for more than 2 months, 65%, 4 months, 70%, 6 months, 75%, 8 months, 80%, 10 months, 85%, 1 year, 90%, 2 years, 95%, and 3 years, 100%. So that's a recovery time we have to assess. Now the gradation. Once you work out the trauma index, if the trauma index from 1 to 10, then it's a mild. And in my previous study, I had studied 185 cases, and it's about 37%. 11 to 50 trauma index is moderate, and 190 cases, that's about 39.6%. 51 to 100 was severe, 117 cases, 23.4%. So that's an analysis of my study of 500 cases, which I published earlier. Now, the second concept of measurement of ocular trauma is by Kuhn et al. Is a very big name in ocular trauma, Ferenc Kuhn, and he published a paper in 2002 with other people, as was known as the ocular trauma score, which many of you are familiar. Now, this is aimed to know the prognosis based on the initial assessment. Now, whenever you get a trauma, the people, the person, the attender, they are terrified. They want to know, doctor, what has happened? How much time will it take? So therefore, you have to give some sort of guideline or some assessment, which will be very difficult. But Ferenc Kuhn et al. Have worked out a formula, and they call it ocular trauma score, and it mainly depends on initial vision. Now, I've already given you the fallacy of initial vision, but anyway, this is what has been done. And other factors are rupture, afferent pupil defect, perforation, and ophthalmitis. Each factor is given and raw point. The total is known as OTS, which is graded. Now, they are the variables which you see raw points in ocular trauma score. The variable is more important in initial vision, and for NLP, the no light percent is 60%, and 20, 40, or 69 is 100. And then you have to add, subtract minus 23 for rupture, minus 17 for endophthalmitis, minus 14 for perforation, minus 11 for retinal detachment, and minus 10 for afferent pupillary defects. So this you have to work out in every case and then find out what comes to the trauma score. Now, what number you get, again it is graded. If the raw points are between 0 and 44, you say it's grade 1. If it's 45 and 65, you say grade 2. 66 to 80 is grade 3. 81 to 91 is 4, and 92 to 100 is 5. So you have OTS grade from 1 to 5. And this will give you a rough, approximately recovery time. Now, briefly, if OTS is grade 1, that means about 74% will become blind. So that's the worst case if NLP is grade 1, if OTS is grade 1. That means about 74% would become almost totally blind, and only 1% would be 6 miles an hour better. This one. So you see 74%. So that's a very, very poor prognosis. Similarly, in between cases, but we come to OTS 5, that's a very good case where no one would be blind and 94% would be recovered by night vision. So this is a gradation which has worked out, and about 11 centers this was done, and they have worked out that this trauma score is fairly good and gives us some idea as to what is a likely prognosis in a given case. Now, limitations of OTS. Only a visual recovery is shown. As I said just now, when you talk of function, it's not only vision alone. You have the intraocular pressure also, the lacrimation also, the fields also, many things. But here we are considering only the visual acuity. Secondly, as I said already, the structural deformities are not considered. That's not very correct in the sense you may have vision may be very good after trauma, but there may be fracture of the floor of the orbit. There may be lacrimal gland may be thrown out. So there could be structural deformities also, which should also be considered, which are not done in this case. And then the final vision depends on the treatment also. Now, how much this has been done in the United States at 11 centers, but the level of treatment in the United States is very different from what is in India. We know that we have got excellent centers in India, all over the country. Nevertheless, we have got a large number of government dispensaries, government hospital in small places where the first treatment is given by a general doctor for any case of ocular trauma. So we cannot predict by ocular trauma score, and that's the reason that there are some papers from India also which do not agree that OTS is very accurate. Nevertheless, it's a good study, and it was done in USA, and as I said, it could not be totally applicable in a developing country like India, and we need to have our own assessment in our cases from various centers. Now, this is the third way of measuring ocular traumagram, this has not been yet published, and this measures the structural and functional loss from trauma. The fields, tension, motility are also considered with visual acuity. Graded measurement is in weeks or months in moderate or severe injuries. So if it's a moderate injury, we grade it in weeks, and if it's severe, it is graded in months. It's constructed on a graph paper from where square centimeters are counted within the traumagram. Each square centimeter is 1 unit of ocular trauma. Now, construction of ocular traumagram is constructed on an ordinary graph paper showing square centimeters. A central vertical line denotes the time interval. 1 centimeter is 1 week for moderate and 1 month for a severe trauma. So there could be 2 types of traumagram. For severe, each centimeter would reflect about 1 month, and in a mild case it will be 1 week. The square centimeters within traumagram are counted, and they stand for 1 unit in weekly and 4 units in a monthly traumagram. Now, construction of ocular traumagram. Now, this is how you see we can start, and this is for a moderate one, and we measure in terms of weeks here. 1 week, 2 weeks, 3 weeks, like that. You get 8 to 10 weeks can be calculated. And on one side is structural loss, and the other side is function loss, and that's again in percentage from 10, 20, 30, 40, like that. So you go on assessing the damage, structural and functional every week. And this you see on the other slide, this is how we go on measuring up to 8 to 10 weeks. And then whatever comes in between would directly give the trauma units. Each square centimeter will stand for 1 trauma unit. Now, what can we have? There are types of traumagram. A type is the standard one, we'll see just now. Then B type is inverted. X type is complicated. Y type is late, showing late changes. H type is parallel changes. K type, the structure is fixed and function is variable. And L type, only structural changes, and then it could be any irregular pattern. So you can have any pattern of ocular traumagram. Whatever it is, we measure the square centimeter within that traumagram and will directly give the trauma units a person has suffered from, and it will be done at any stage. Now, this is a type of traumagram where you find that the maximum is the commonest type, where the maximum damage is done in the earlier stages, and as treatment or natural course, it goes on improving. And in this case, there's the commonest one, and you get 80 square centimeters, that means 80 units of trauma. So So we can measure directly in 80 units. This is A type of traumagram. This is an inverse traumagram. Initially there may be no loss, but as time increases, you find the changes are getting more and more. Then there's an X type. Initially there's improvement, there was some complication in between, and again the damage has started. So that could be an X type of traumagram. This is a Y type of traumagram. The loss may initially be much less, but as time goes, it goes on increasing. So this here, the loss is 28 square centimeter or 28 units of ocular trauma. Then this is a H pattern of traumagram, where you find both the structure and functional loss are running parallel with time. So this would be H pattern. The K pattern, structural changes are fixed, but the functional changes are variable. Another L-type pattern where structural loss, the only structural changes, the functional loss is only limited and doesn't grow further. So any type of, you can have a change, and you have to measure the square centimeters within that traumagram and will convert into trauma units. Advantage of ocular traumagram, exact calculation is done for the structural and functional damage due to ocular trauma. Weekly, monthly, and total assessment can be done. Effect of treatment and or complication can be noted. Takes into account damage to ocular adnexa also. Limitations of ocular traumagram, it requires a long-term follow-up, and is better if the case is admitted for some time, and patient's cooperation is necessary, otherwise usually it's not very good. The structural loss depends on clinical judgment. So that's another thing. So you have to have clinically you have to assess. Still, something is better than nothing. So it gives at least some quantitative value, which may not be very, very accurate. Nevertheless, something is better than nothing. You have something to count upon. To conclude, by ocular traumagram, total loss can be assessed in different persons at different times. The impact of treatment and complications can be judged. In traumagram, the total loss is directly read from graph paper in trauma units. Each square centimeter corresponds to 1 unit in weekly and 4 units in monthly traumagram. In all methods, there are some element of subjectivity, hence in all methods, accuracy cannot be very high. Yet quantitative assessment is valuable for many reasons. It gives some idea of the severity and prognosis of a given case. Quantitative assessment is important in giving compensation for injury in industries. Thank you for your non-traumatic attention. Thank you.